Good evening, everyone, and thanks for attending. I believe this meeting is heavily oversubscribed, so I'm sure it's the topic that's the draw, not the speaker. But anyway, this meeting was put together after a conversation that Mike Howe from Celtic SMR and I had just after the lockdown. We had a number of ultrasound meetings planned for the year, and then with lockdown and COVID-19, all these plans had to go out the window. So Mike suggested, well, why don't we do a series of webinars and do the CPD that way. So after a bit of toing and froing and planning, what we decided to run over the next few weeks is a series of practical webinars. So the first one tonight is liver and spleen. After that, we're going to look at bladder and kidneys as the next webinar. Adrenals, pancreas, lymph nodes as the one after that, number 3. Echocardiography, number 4. And then we'll maybe do Doppler echoes, number 5. So they're still in the planning at the moment. I haven't finished them, but we'll see how they go. I think one of the challenges that we had with this was a technical challenge, in that a lot of ultrasound is video, and certainly from a teaching point of view, video is really useful. But technically, beaming that out to you guys out there is not an easy thing to do. Is that someone that's just
Hi Mark, it's Peter here. I think we've got a few people in the chat saying they can't hear you. Some can, some can't. I can see I can hear you, so I know you're not muted, but
yeah,
I'm not quite sure what's happening there. Sorry everyone.
Definitely not muted. Can everyone actually see the screen okay? And is the quality of the image on the screen okay? And this may be down to your own bandwidth, which could be a limiting factor. And if that's the case, there's probably nothing that I can do about that, unfortunately. So I'm just going to crack on if that's okay, Pete?
Yeah, I think so, Mark. Most people seem to be able to hear. Sorry to everyone who can't.
Okay, so tonight's topic is practical ultrasound of the liver and the spleen. And I'm going to start with a tip of the day, and that is never, ever, ever perform a liver scan or a spleen scan. I would always urge you to perform a full abdominal ultrasound scan, because if you do just a liver scan or a spleen scan, you're bound to miss something, and it will come back to bite you. So although we're talking about liver and spleen tonight, we would be wanting you to do a full abdominal ultrasound scan in practice. So here's the topics that we've got for tonight. We're going to kick off with a bit on patient preparation. We really have to start at the beginning here. So patient preparation, we'll talk a little bit about probes. We'll talk about understanding the buttons. That's what I call driving the ultrasound machine. And then we'll talk about optimizing the image. And the liver and the spleen are two very different organs in terms of optimizing your imaging for these organs. Then we're going to talk a little bit about some clinical cases, so nothing highbrow at all. And we'll finish off. We're going to have a break. And then I'm going to set up this machine that you can see here. This is the P50, Sonoscape P50. We're going to set this up and actually scan my dog, and I'm going to try and stream this to you live. So it's a bit of a risk. We'll see how it goes. I hope it goes well, and I hope that you can all see the videos that we produce. So I think a good starting point is to just talk about good practice when you're doing an ultrasound scan. I go into a lot of practices with my job, and you see the ultrasound machine sitting in the corner, and the gel's all dried on the probes, and you look at the clippers, and the clippers are filthy. I think it's good practice to make sure that your clippers are well looked after, well maintained, that they don't have jagged teeth, and that they're clean. Because the last thing you want to do really is send your patient home covered in scratches, or even worse, the client having to come back for some antibiotics because the dog's developed a skin infection. So clipper maintenance, I think, absolutely essential, and probe disinfection between patients. It's worthwhile thinking about that as well. I use these Tristel Solo ultrasound wipes, and I wipe my probes between each patient, so that I can satisfy myself at least that I've done everything to prevent any cross-contamination. So how do I like to prepare my patients? I like my patients to be starved overnight. And then when it comes to clipping, you want to do a proper clip. So what I mean by that is that it's a full clip from the caudal ribs right the way to the pubis, and it needs to be quite high. So I think it's really important that the owner is made aware of just how high you're going to do that clip. Make sure you've got permission, make sure they're well warned. And if you've got a consent form for that, I think even better, to make sure that the communication is done properly. And then I personally like to apply some spirit to degrease the skin and improve the gel soaking into the skin. And I'll hear some of you gasping in the background there, because I think there are some manufacturers of ultrasound machines and ultrasound probes who say don't ever let spirit come anywhere near your probes, because it will damage the probes. My take on that is that spirit, if you allow it to dry thoroughly and it's completely dry, it's evaporated before you get started, it shouldn't damage the probes. But if you have a policy in your practice that says otherwise, then I would go with the practice policy. The next thing is to make sure that your gel is soaked in well into the patient, and even better if you can get a nurse to do that about 15 minutes before you start. It can really make a difference to the quality of the imaging that you can do. So the next thing to think about is looking after your patient and make sure that they're comfortable. So I like to have my patients on a nice soft bed, and I like to handle them as gently as possible. Take your time with them. I use loads of these things: Adaptol, Feliway, Pet Remedy. I'm sure there's lots of other ones. But really it's to try and get the patient as calm as possible. And especially if I'm doing an echo, these are great things for echocardiography when we really don't want to sedate. So I do like to sedate my patients for an abdominal ultrasound scan, because I think certainly if you're doing a very detailed scan, you need that abdomen to be as relaxed as possible. So in my opinion, sedation is quite important. The next thing to think about, especially this time of year and after the lovely day that we've had, if you've got air conditioning, I think that's a real boon, because the last thing you want is a dog that's panting and panting and panting, because it really impacts on the quality of the imaging that you can do. And then lights out and off to go. So if we talk about probes, ultrasound machines come with lots and lots of different choices probe-wise. But if we were just going to have a look at the go-to probe that you would want for doing an abdominal ultrasound scan, I would be thinking about a microconvex probe that is capable of running at a middling range. So, sort of between 8 and 4 megahertz maybe. And that would be the sort of probe that will do most of your abdominal ultrasound scan. If you've got the luxury of having a second probe, I would be thinking about having a linear probe like this one here, and that would be a higher frequency probe. So higher frequency probes run at a higher frequency, and what they do is they allow you to see fine detail. So they're good for fine resolution, but that is at the expense of the depth. High frequency probes are maybe not so good at penetrating deep into tissues. So really, for doing an abdominal ultrasound scan and doing a really thorough abdominal ultrasound scan, I do tend to chop and change between different probes depending on what I'm wanting to see. So for a liver, for example, your starting point certainly would be a middling range probe that is capable of running at quite low frequencies to allow you to get the depth of penetration that you need to see into the liver. And then for all you learner drivers out there driving your ultrasound machine, I think it is really important to be able to understand how to drive your machine, what all the buttons do. So I think your starting point, at least when you're doing an abdominal ultrasound scan, is select your probe like this, and then tell the machine that you're doing an abdominal ultrasound scan. You don't want to be using an echo setting to do an abdominal ultrasound scan. Sounds really basic, but it's so important that you do select things properly, because it makes a huge difference to the quality of the imaging that you can do. The next thing to be able to understand is what I call the 4 magic buttons, and I'll explain what they are in a minute. But the 4 magic buttons are the depth, the gain, the time gain compensation, and the focus. So let's drill this down into what these different buttons do, because it's really important to understanding how to drive your ultrasound machine. So the depth essentially is just the number of centimeters depth that you're scanning into the tissues. So for an abdominal ultrasound scan, I would be thinking about altering the depth all the time during that scan. So what I would want to do is find, for example, here you've got the left adrenal, find the area of interest, and that should fill about 3/4 of the screen. Move on to the next structure, the kidney. We'd want to change the depth again so that the kidney fills 3/4 of the screen. If we want to then move to the liver can be, you know, sitting at 10, 12, even 15 centimeters depth. You want to change the depth so that you can see the whole of that liver. The next button to think about is your gain. And the gain you want to set so that it's not too high like this. That's a very snilly image. And you don't want to have your gain too low so that it's very dark. So it's just a case of adjusting your gain just to get it right for your own eye and for your own like. The next thing to think about of the 4 magic buttons is the time gain compensation. And the time gain compensation is simply a gain switch that corresponds to a part of the screen. So this first gain switch corresponds to this part of the screen. This gain switch here corresponds to that part of the screen, and so we go on all the way down. So what you can see in this example here is I've turned the gain down for this portion of the screen, and you can see this dark area as a result of the gain being turned down. And then this one here, what we've done is we've increased the gain in this portion, and you can see the gain in a band across the image that you can see there. Why is that important? That's important because it allows you to alter the gain at different portions of the screen so that you can even up the image. And the great example of that is if you're scanning the liver. What you sometimes find when you first put your probe on the liver is that the image is too bright at the top here, yet it's too dark at the bottom. So what you'd want to do is touch the gain up in the bottom portion of the screen and maybe knock it back a little bit in the top portion of the screen. That way you can see that the image of the liver is even all the way through it. So that's the time gain compensation. The next one, and one that we all forget about, but is really, really important, is the focus. And usually when the focus is running, you can see them as 3 little triangles, or sorry, on this screen, in this one it's 3 little triangles, but the focal point is a triangle that shows quite often, or a dot on this side of the screen or the other side of the screen, and that shows you where the focal point is. So what you want to do is whenever you get to an area of interest on the organ that you're scanning, you want to just think about getting the focal point level with the area of interest, because what you will find is that the machine settings in the background will alter as you move the focal point up and down. to optimize the area of interest that you're looking at. And okay, in some machines you can increase the number of focal points. I think one of the downsides of doing that is it quite often it reduces the frame rate. That's the 4 magic buttons. It's also important, I think, to think about the frequency that your probe is running at, because with most modern probes these days, you can actually alter the frequency range that the probe is running at. So what you would want to do, the example on the left here, is I've turned the frequency range down so that it's running, the probe is running at a lower range of frequencies, and that would be for optimizing good penetration. So you might want to alter the frequency and drop it down for doing a liver scan. Whereas if you select a high frequency range, then that is for better resolution. That will give you better resolution, but it may not give you the same level of penetration. So if we're comparing, tonight we're comparing the spleen and the liver. If I was looking at the liver, as I say, I would want to maybe select a lower frequency to get good penetration. But if I was scanning the spleen just sits 1 or 2 centimeters below the skin. So we don't need that penetration. So it's okay to crank up the frequency that the probe is running at, or even better, even swap to a high frequency, that linear probe that I was talking about before. That can really optimize the quality of the imaging that you can get out of your splenic scan. And then there are other settings in the machine that you can twiddle with and change. So dynamic range is one of them. And here's a good example on the left. This left adrenal is running at a higher dynamic range. So what you get is a less contrasty image, but more fine grayscale. Whereas with a lower dynamic range, what you've got is a very, very contrasty image. So what you're seeing is very black and the white is very white. So I would argue that our dynamic range probably is useful for looking at the heart, whereas a higher dynamic range or compression is useful for looking at fine differences in grayscale. So for an abdominal scan, I think that's something that would be useful to change. So it's being able to understand what these different buttons do when you change them. And then most machines, there's other buttons that you get, and these are less important to your scan. But there's zoom, for example. I use zoom all the time in both abdominal ultrasound scans and in echoes. So here's an example. This is my dog from the other day, and this is me scanning her liver. And I've basically taken the zoom and blown the whole image right up. See how much more detail you can get with that. I'll just do it once more. I'm going to have a little drink at the same time. It's not wine, by the way. Too early for wine. So that's zoom. Great thing to have on an ultrasound machine. Fantastic. Other buttons to consider. Calipers. I think almost every ultrasound machine these days has calipers. So again, back to this adrenal gland. If you've got calipers or you find a lesion, I would say measure it, because these calipers can measure quite accurately. And certainly for the adrenal glands, once you've found the adrenal glands, we really want to know exactly how big they are, because that can help with your diagnostics. And then there's other buttons, labeling. You can label, you can annotate, you can put arrows in, you can change the color of the map, the color map or the chroma map. And also be aware that whenever you press the freeze button, if you go to the tracker ball on most ultrasound machines, you can scroll back, and some machines have got the ability to replay and replay in slow motion. So here's an example from a dog that I scanned 2 days ago. So this is a dog's liver. It's very, very abnormal on the left. So this is your normal black and white ultrasound imaging that you've got here. And the image on the right, what I've done with that is I've changed the color map. So the chroma map has changed. just to see if we can see any more detail. I've added some arrows to show where the liver is, and I've annotated it as well. And I've also used the slow motion loop playback so that you can see things again in more detail. So these are useful things. They're not essential, but they're useful things to play with and to help you with your imaging, and ultimately to demonstrate to the client what you've been doing when you've done your ultrasound scan. So other things that you can do to improve the image, it might sound really simple, but if you're struggling to get a good image, you can change the distance or reduce the distance between the probe and the area of interest. That might just be by moving the probe into a different part of the body to look from a different angle. It may be pressing harder or less hard. I think there's a sweet spot as well where you just get at the right pressure, you just get the best image. And that's something that comes with experience, comes with time. And other things, tips if you like, things that you can do, you can pull the fur away sometimes if you haven't clipped enough, or the client won't allow you to clip enough fur. Sometimes you can just move the skin out the way to give you a bigger window into the area that you're interested in, or even just to try soaking some more gel into the area. It's not ideal, but it's just something else that you can do. And then ultimately, one of the other things to think about is to swap your probe for a higher frequency probe. As I said before, when I'm doing an abdominal ultrasound scan, I'll use the microconvex probe as my go-to probe, and I'll use the linear probe to look at the high detail of structures. So small structures close to the skin, anything that I want to see in high detail, I would want to use the linear probe. And we'll have a play with that tonight. Hopefully that will work when we do a live scan as well. So before we move on to just looking at some images, it's worthwhile just thinking about the physics of ultrasound. So I said nothing highbrow. I like things to be really simple. So this is my view of understanding the ultrasound image and how it's displayed on the screen. So different tissues have got different levels of echogenicity. So what you find is that bile, urine, and fluids tend to be black. And then soft tissues tend to have increasing echogenicity. So through muscle, renal cortex, liver, fat, spleen, prostate, these soft tissues have got increasing echogenicity. And then when you get to bone, gas, and organ boundaries, you find that the ultrasound image is displayed as hyperechoic or white. So if I was to summarize that, what I mean by that is that fluids are black, soft tissues are different shades of gray, and bone, gas, and organ boundaries are hyperechoic or white. Simple, hopefully. So let's look at the liver. The liver is split into different lobes. It's a big organ in the body, and if you do not scan the liver systematically and scan the whole of that organ, you will miss things. So it's really important that you just think about the anatomy, where everything's located, and make sure that you satisfy yourself that you've scanned the whole of that liver. So what does it look like, the normal liver? Normal liver has got a coarse echotexture. So what you can see here is I've put a liver on the right, and a spleen on the left. So the liver has got is coarser than the spleen, coarse echotexture. It's a medium echogenicity. It's darker than the spleen when you see them side by side. The portal veins are the dominant vessels, and these are the ones that have got the hyperechoic walls. And the hepatic veins are the ones where you can't see the walls at all. And the hepatic veins tend to drain dorsally and into the caudal vena cava. The main portal vein enters the liver at the porta hepatis, and that's on the right. The gallbladder you find to the right of midline as well. And we'll talk about this a little bit later, but the gallbladder wall is normally less than 1 millimeter thick as well. So how do you approach a liver scan? I think, as I said before, you must make sure that you scan all the liver lobes and try and do it in at least 2 different planes. So I tend to try and do a long axis view of the liver on the left, the mid portion, and the right, and then a short axis view on the left, mid portion on the right. And I tend to do an intercostal view as well, especially in some of these dogs where the liver sits, right up and under the rib cage. I think that's important. So to be able to do all of that, you tend to have to look at the liver with the dog in right lateral recumbency, left lateral recumbency, and dorsal recumbency. I know some sonographers like to do it in dorsal recumbency, and they can do the whole thing in dorsal recumbency. It's just what your preference is. The other thing to think about is that when you're scanning the liver, the cranial portion of the abdomen, that's an opportunity for you to look into the diaphragm. And I've diagnosed no end of pericardial effusions, pleural effusions, masses in the chest, just simply because I took the time to look through the diaphragm to the other side of the diaphragm and into the chest. So don't forget to do that when you're doing your abdominal ultrasound scan. And then what I like to do is then focus on the liver, look at the liver size. So if the liver comes beyond the costal arch, I would be thinking, well, this liver could be enlarged. Look at the liver lobe edges. Are they sharp and pointy, or are they rounded? Because that will give you an idea as to whether the liver is swollen or not. I would ask the question, is there an abdominal effusion? What's the albumin level, blood albumin level? I then look at the gallbladder, and things to think about is the gallbladder, the bile duct. Is there any evidence of obstruction to flow of bile? Assess the porta hepatis, caudal vena cava, and the hepatic vasculature. Sometimes we'll use colour flow Doppler just to have a look at lesions. And then if you have evidence of dilated hepatic veins, so these are the ones that don't have white walls to them, I would be wanting to ask the question, okay, if there's hepatic venous congestion, is there something going on in the heart? What's the differentials for hepatic venous congestion? So right-sided congestive heart failure, pericardial effusion, tamponade, and obstruction to the caudal vena cava. So if I can't find a reason for it, I'm thinking about following the caudal vena cava forward as far as you can possibly go to see if there's any evidence of obstruction. And if you still don't find anything, the next thing to do is to do an echo and see if you can see a reason for it there, chest x-ray or a CT scan, or both, or all of them. So here's the technique. I tend to start in the middle, in the longitudinal plane. So the button is where my thumb is, and I'm pointing fairly cranially from that point. So that's your longitudinal plane centrally. And then I sweep up to the left, again in longitudinal plane, sweep down to the right, again in longitudinal plane. So I've looked at the central portion, the left portion, and the right portion. Then what I do is I rotate my probe 90 degrees. So now the button is facing the dog's spine. And then I'm going to sweep the probe cranially and caudally in the central region. And again, do the same thing in the right side of the liver, and the same again in the left side of the liver, so that I can satisfy myself that I've scanned the whole of that liver. And I would do that with the dog in right lateral recumbency, as I said, dorsal recumbency, and left lateral recumbency. And then even have a look intercostally as well, if you can't satisfy yourself you've seen the whole of that liver. So, okay, here's some normals. So this is a normal liver that you can see here. We're pointing down to the right, it looks like, because we've got the gallbladder. You can see the diaphragm, diaphragmatic line. This dog's obviously sedated. I can see that the heart's just beating the other side of the diaphragm in the chest. And you can get an appreciation of the fact that this dog's liver lobe is pointy. So it's not rounded, it's not swollen. And if you look carefully as well, there's two liver lobes here, and you can see them both sliding against each other. So here's one lobe, and here's the other lobe. If you look carefully, if you've got good quality imaging, you can see these lobes sliding against each other. I always say be aware of the structures that lie close by, because I've had no end of people say, I think there's a mass in this dog's liver, and quite often it's the stomach. So the stomach just sits caudally. So this dog breathes in and out. There's the liver, there's the stomach. Hopefully you can see that. That's normal liver. So what about liver abnormalities on ultrasound? We often classify these as focal, multifocal, or generalized. And we say that nodules are less than 3 centimeters, masses are greater than 3 centimeters. And then we talk about the echogenicity of the abnormalities. So they can be anechoic, hypoechoic, heteroechoic, and hyperechoic. Hypo, hyper, yeah, and hetero. And these will give you some differentials depending on what you're seeing. So anechoic lesions tend to be cysts, necrosis, abscesses, cystic tumors, or bilomas, so they're basically fluid. Hypoechoic tends to be nodular hyperplasia, hematoma, lymphoma, complex cyst, metastasis, primary neoplasia, and necrosis. And so it goes on. Hyperechoic, there's a whole load of differentials, and there's a whole load of differentials for mixed echogenicity. So you can't actually say from looking at a liver lesion exactly what it is. All you can do is give a list of differentials. However, if you see a target lesion, so that's a lesion where you've got a hypoechoic rim and a hyperechoic center, it's said that that gives an 80% positive predictive value for neoplasia or metastatic disease. There was a paper that was published in JSAP, March 2012, that looked at liver lesions on ultrasound to see whether you could make a tentative diagnosis based on what you saw. And what they found, what they concluded was that really, at the end of the day, to get a diagnosis, you need to take a biopsy. So you can't really tell what the lesion is just by looking at it. However, I think you get a good impression. So here's some examples of some abnormal livers. So this is a cat's liver, and this liver has got multifocal, generalized, mixed echogenicity masses. And if you look at the corner of this liver, just here, on the edge of this liver, as we play this video back and forth, some of this liver is rounded at the edges as well. And then we see things like this, multifocal hypoechoic nodules. So we think about all the differentials that could be. Quite often these can be vacuolar hepatopathy. Some of these Cushing's cases look like this sometimes, and that would be confirmed on an FNA. And then this is the same dog, and what I've done in this case is change probes to a linear probe and a higher frequency probe, just to show you how much detail that you can see. So if you have a look at this, you can see much more detail of these multifocal hypoechoic nodules. And then here's something which is a focal hyperechoic nodule. So if I remember rightly, this was a diabetic dog, and this was just an incidental finding in that diabetic dog. And then this is a cat that has got multifocal mixed echogenicity nodules and masses. And as you can see, there's an effusion here, and it's quite cellular fluid. And these have got the impression that these are target lesions. So the hypoechoic around the edges, hyperechoic in the middle. And in fact, I think there's some central necrosis going on. And I would be thinking about neoplasia there, absolutely, for sure. And then if you've never seen cirrhosis or an end-stage liver, this is the sort of thing that you'd see. So the giveaway is that you've got an effusion because of the blood albumin is so low. And this liver is hyperechoic and fibrotic, and the outline is rounded. There's no sharp edges to it at all. And the outline is irregular as well. So that's an end-stage liver, unfortunately. And then this was a Labrador that came in, and this is a breeder's dog. And he came in and he said, "Oh, Poppy, her abdomen's really swollen." And I looked at him and I said, "Robert, you know, are you sure the dog hasn't just jumped the fence? Because that would be the most likely thing in your case, because you're hopeless." I know the guy really well, by the way. Anyway, I had a look at her and I thought, "Oh, this abdomen is swollen and there's a fluid trail." So I popped the scanner on, and this is what I found. So there was a lot of fluid in the abdomen, large volume ascites, and I looked at this liver and I thought, this liver doesn't look normal at all. In actual fact, the biochemistry, the blood work was not very helpful. And the long and short of it was that I ended up opening this dog up to have a look and to take a biopsy. And this was the fluid that we got from the abdomen. And this is what the liver looked like. It was a bit fibrotic. It just wasn't normal at all. So we took some biopsies, and this came back as a fibrosing and chronic active hepatitis with vacuolar hepatopathy. And interesting, this dog did make a good recovery with treatment. And then don't forget other things that you find in the liver. So I talked about hepatic venous congestion before. This is what it looks like. So you get a big fat hepatic vein. So there's no bright white walls to that. It's not a portal vein, and it is big within the liver. So my eye is then drawn to the other side of the diaphragm to see what's going on. It's not clear in this one, but this one did have a pericardial effusion. So this was a tamponade case. And then if we look at the gallbladder and the biliary system, we find the gallbladder over to the right of midline, and its size can vary. I get a lot of people that say, "Oh, you know, I've scanned this dog and its gallbladder's huge, it must have an obstruction." And what you have to remember is that if a dog has been starved or anorexic, then quite often the bile will collect in the gallbladder. So you can have quite a big gallbladder without there being any pathology there at all. Gallbladder wall tends to be normal, would be less than 1 millimeter in cats and less than 2 to 3 millimeters in dogs. And quite often in some dogs you will see a bit of sludge in the gallbladder. That's not always abnormal. So if you're seeing a line where gravity has allowed the gallbladder sludge to settle, then that would be sludge rather than anything else. It's unusual to see gallbladder sludge in cats, and that would be more representative of cholecystitis. And the common bile duct. So if you're trying to decide whether you've got biliary obstruction, I would look at the common bile duct. The normal in dogs is up to 3 millimeters, and normal in cats is up to 4 millimeters. In the normal bile duct in dogs is more difficult to see, or it's less commonly seen. So if your bile duct is enlarged, I would be having a hunt to see whether there's any evidence of an obstruction. So I would try and follow that all the way to the duodenum if possible, and see if it's obstructed at any point along the way. So here's some examples of abnormalities. So if you ever see a kiwi fruit in the gallbladder, that's most likely to represent a gallbladder mucocele. So what you get is this stellate pattern that's talked about, these straight striations that come off the central portion. And here's another example here. So you can see that you've got this mucocele in the middle, that stellate pattern. And you can almost imagine this is real sludgy, sticky, mucousy stuff that's in there, horrible stuff. It's interesting. The presence of Cushing's disease increases the risk of gallbladder mucoceles by 29 times. I read that somewhere. So I would always be thinking about, if I find a gallbladder mucocele, A, it's worthwhile getting a size for the adrenal glands and see if there's any evidence of Cushing syndrome, and B, probably you want to be talking to a surgeon in case this thing ruptures. And then some other incidental things that you sometimes find, not commonly at all, but this is a relatively recent case, and this dog had some gallstones. So what you're seeing is a bright hypoechoic signal, which represents the stone, and you can see some shadowing artifact beyond that, which is showing that you've got a really solid mineral type of density. So what about the spleen? Anatomically, we just think about where the spleen sits. It sits on the left-hand side and tends to form a strap-like structure that sits just under the skin and runs across to the other side. So what does it look like in ultrasound? Well, it's got an echogenic capsule. The parenchyma is very homogeneous and finely textured, and it's got a medium to high level echo pattern. So that means it's brighter compared to the liver, and the liver's more coarse and slightly less echogenic. So that's how you differentiate the spleen and the liver. And in actual fact, you can, in some dogs, if the stomach's not full, you can actually get the spleen and the liver sitting in the same image, so that you can compare the echogenicity of the two different types of tissue. So where do we start? I tend to start on the left and set your depth to shallow. So the spleen is one of these organs where, you know, you can really go to town on your frequency. You can crank the frequency right up, or even change to a linear probe, because this is so superficial, and you can get some beautiful detail of the spleen that way. So you set your depth to shallow, get your focal point in line with the spleen, as I say, high frequency probe, but make sure, just remember it's a big organ, so scan the spleen all the way down until you run off the end of it, and then that's in the short axis, and then do the same in a long axis view all the way down. And remember, there's a portion of spleen that sits up and under the rib cage here, and so you have to actively think about looking up there. I've seen masses tucked under here before that have been missed, just simply because a probe's not been put up into that region. So don't forget to do that as well. So what about optimizing the image of the spleen? Well, this one gets the thumbs down. So what is wrong with this? I think the depth setting is just rubbish. See, you're not seeing any detail to this spleen at all. And this is why driving your ultrasound machine is so important. It's important to know how to change the depth and how to change your focal point, and how to change your gain, etc., so you can really see what's going on. So that's rubbish, the way that one's been optimized. Here's your next one. So I've got this, given this a thumbs up. So this is a normal spleen microconvex probe, and actually it's my dog Nell that I scanned the other day using the P50. And then, yeah, we've moved to a linear high frequency probe here, and look at the detail you see. I think actually my depth could be optimized a bit better than that. But yeah, that's a nice view of the spleen, looking at the detail. So that's normal spleen. So what about the abnormal spleen? So this is a dog that that came in. It was a little bit pale, a little bit tachycardic, and when I put my hands on the abdomen, I just felt it was a small fluid fill, and I was thinking, I bet you this dog's got a splenic rupture or something going on. Popped the probe on, and this is what we saw. So here's the spleen here, and you can see quite clearly there's a mass of some sort on the end of the spleen. It's cavitating, so I've got a high index of suspicion for hemangiosarcoma, and it looks like it's ruptured. So the next thing to do was to get this dog opened up, and this is it, just the last part of the spleen being removed. And here you can just see where that lesion is, just here. This was confirmed as a hemangiosarcoma, but do remember that there are other things that can cause mass effects on the spleen, and I've seen some before that look as if they're going to come back as a hemangiosarcoma, and they've come back as hematomas. So it's always worthwhile sending these off for histopathology. And I'm sure we've all seen these in practice, lots of them. So here's another spleen. This is a dog that had a pyrexia of unknown origin, and I scanned this dog as part of the workup, and we really couldn't get to the bottom of why this dog had this pyrexia. And I found this on the spleen. I couldn't really link that with the pyrexia at all, but my concern was that looking at this, there's quite a thin capsule to this, and this is at risk of rupturing. So I discussed it with the owner, and the owner said, yeah, I think we should take this out and send it off and see what we get. So this is what it was. It didn't look like anything nasty at all. And there was another lesion on the other end as well, as you can see there. So what came back was splenic nodular hyperplasia, but the pathologist did say that it's not uncommon for hematoma formation to occur, and these can rupture, causing hemoperitoneum. So I felt maybe justified in doing what I did. But lo and behold, this dog's pyrexia of unknown origin suddenly disappeared. And the only explanation I can give for that is that I let the evil spirits out, because there's nothing scientific, I don't think, about what we did. But yeah, I felt we'd done something for that dog. So here's one of the more unusual spleens. So this has got lots of hypoechoic nodules in the spleen. I didn't like what I saw when I saw this one, and we discussed it. The owner wanted me to just do an excisional biopsy, and this was it being performed. This is with one of these lovely LDS staplers, which I'm not sure you can get anymore. It's air driven. I used to love this boys and toys, isn't it? I used to love this. Brilliant. So you can whack a spleen out pretty quickly with one of these pieces of kit. But this came back as something that I'd never heard of before: hemophagocytic histocytic sarcoma, with a pretty grim prognosis. Again, the owner got the answer as to what was going on there. And then this is a bit overgained, but I thought I would put it in if you've never seen it before: lymphoma in a spleen. So if you see multiple small hypoechoic nodules and with a spotted echotexture, that is highly suggestive of a lymphoma. And don't forget, when we're talking about splenic disease can also be a cause of ectopic ventricular rhythm. So if you're trying to work out why a dog has got a ventricular rhythm and you can't find a cardiac cause, it's always worthwhile just scanning the spleen to see if there's any pathology going on in the spleen. And the other thing, while we're talking about it, if you do find a splenic mass, always scan the heart, because 25% of dogs with splenic hemangiosarcomas also have a concurrent mass in the heart. And if you're looking for where to find that, it's usually at the junction of the right ventricle and the right atrium. So if I just play this next video, here's the spleen, and you can see quite clearly there's a mass in the spleen. So we then did an echo, and lo and behold, there's also a mass at the junction of the right atrium and the right ventricle. So this is a right parasternal long axis view of the heart: right atrium, right ventricle, left atrium, left ventricle. So here's your mass here. So that's concurrent right atrial and splenic hemangiosarcoma.